Yeah, are we recording? Yeah, we are. Okay, brilliant. So thank you for everyone that has registered to attend this webinar. I really hope that you find everything within this really useful and informative. Jordan, if you could go on to the next slide for me, please. As I've already said, pop your name and job title in the chat, and if you can pop your email in the chat too. It's just going to allow us to be able to network and to speak with everyone. Afterwards, there might be some links and connections that we can get from this. In terms of what we're going to be achieving today, so we're going to have a brief introduction from Councillor Khan, who is the Health and Social Care Councillor for Birmingham. She's provided us with a video to talk about the importance of cervical cancer screening and also the community health profiles. I'm then going to give a bit of an overview of the community health profiles, what the profiles are, and how they're relevant really to cervical cancer screening and prevention. I'm then going to pick some of the cervical cancer information from the profiles, and then Donna is going to kindly come in and discuss the importance of cervical cancer screening and barriers to screening. Donna is a Queen's nurse, and she does lecturing for BCU, so she's a really good. It's really good that we've joined up with her, and thank you very much, Donna, for joining with us. And can I please ask that everyone can mute their mics if they are not speaking? If you do want to speak at any time, I'm really open to how people want to speak. So if you want to turn your mic off and speak, if you want to turn your camera on while you do that, then that's brilliant. If you want to ask a question in the chat, then that would be great as well. I know we've got quite a few people in here, so I might need a few people in the communities team to discuss that or to raise it with me, but that would be absolutely brilliant. Please turn off any VPNs. That's going to help save bandwidth and make sure that everyone can listen to this webinar properly. As I've already said, use the chat function or raise your hand if you would like to speak or to discuss anything throughout the webinar. And we are making sure that this webinar is recorded. We really want to make sure that we can share this with as many people as possible. So the recording will be added onto YouTube. We will share it with all attendees once it is on YouTube or sitting on our public health website. And we'll also share it with anyone who said that they weren't able to attend, but wanted to see some of the information from the webinar today. Brilliant. Next slide, please. Brilliant. So as I've said, Councillor Khan, Jordan, if you could just flip onto the video, then that would be great. And we've got a 2-minute video from Councillor Khan today.
Hello everyone, I'm Councillor Mariam Khan, Cabinet Member for Health and Social Care at Birmingham City Council. I'm delighted to be welcoming you all to our webinar for Cervical Cancer Awareness Week 2023, where we will be discussing the inequalities in cervical cancer screening amongst different communities by looking at the information presented in the community health profiles. I am proud of how diverse Birmingham is and of how welcoming we are to those who choose to make this city their home. However, we know that not all of us experience the same levels of good health and well-being as each other, and that there are real differences between communities. In the Council, we take this seriously and see tackling these unfair differences in health as a core component of the work that we do. The community health profiles have identified and summarised the physical health, the mental health, lifestyle, behavioural and wider determinants of health-related issues affecting local communities, both locally and nationally. The findings from these key public health documents will help shape how we address, protect and prevent health inequalities in our city. We've always struggled with understanding the detail of some of these inequalities, and this is where our community health profiles come in. The Public Health Communities team have, in partnership, developed profiles on a range of communities in Birmingham based on ethnicity, faith, disability, sexual orientation and gender identity. Where data is available, the Protect and Detect section of each profile contains valuable data on cervical cancer screening rates in different communities and discusses specific barriers affecting their uptake of screening. This data will help to improve our collective understanding of these barriers and the related inequalities so that we can work together to address them. It is so important to understand the barriers faced by people in order to support health colleagues and to encourage more people to be screened for cervical cancer. Thank you.
That's great. Thank you, Jordan. And thank you, Councillor Khan. Next slide, please, Jordan. Brilliant. At some stage today, we will be using Mentimeter. So for those of you who haven't used Mentimeter in the past, it's a way of interacting with some of the questions that we have within this webinar. If you want to get that set up nice and early, the Menti will come later in the presentation. But if you do want to make sure that you're on that nice and early, then the website is www.menti.com and enter the code today for this webinar 45195803. And if I could ask somebody in the team to pop that code into the chat as well, that would be brilliant. It's not going to come up for a little while yet, but good to get everyone ready for that. Next slide, please. Brilliant. So the community health profiles Councillor Khan talked about in quite a lot of detail already. The cervical cancer screening information is found in protect and detect sections. I think it's really important to note that because we've got so many people in the room from different healthcare settings and from different health related organisations, these profiles contain a lot of information about a lot of other health related topics. So it goes through getting the best start in life, which will cover infancy and pregnancy, and it will go all the way through the life course towards aging and dying well. It covers a wide range spectrum of health related inequalities. So there's loads of information and loads of evidence that people can use and people can pick to help inform some of their decision making. If somebody from the communities team could pop the link in the chat just to the overview page of the community health profiles, and that would be brilliant. Really do engage with those materials. And if you want to use any of the infographics, any of the data, it's all there for people to use. The worst case scenario for these is for them to sit on the website and for them to not be used. So I really actively encourage as many people to engage with those materials as possible, and for people to start using them in their work. They do really provide specific information about the health related inequalities. In terms of the profiles that we have published so far, you can see those on the left-hand side. Councillor Khan's already said that they cover ethnicity, disability, religion or faith, and the LGBT plus community. We do have some more upcoming profiles that will be produced in the next financial year. So those cover, again, the same kind of groups, gay men, bisexual, Central African, South African, Latin American, Chinese, Irish, Central and Eastern European, Gypsy Roma traveller and the student population. So we will have those out. We have some webinars that we produce for each specific community health profile. We will be producing more community health profiles in the upcoming months and within the next year. So keep an eye out for those. We'll make sure that we keep inviting people along to those. And I hope that everyone finds them helpful if and when they do come. Next slide, please. Brilliant. So in terms of what the community health profiles aim to do, they aim to find and review physical health, mental health, lifestyle, behavioural and wider determinants that exist in health in a specific community. We do this in terms of collecting and presenting this information using key priority areas identified in the health and wellbeing strategy for Birmingham. We engage with the local communities on the evidence found and highlight the opportunities to address inequalities. I think it's really important to mention at this stage that they are desktop pieces of research. We collect all the data that is published on the community, and then at a later stage, once the profiles have been developed, we will then work with engagement partners. Those engagement partners can detect the sensitivity of the language used within the profiles. They can also help us to disseminate the profile amongst the community, and they can also help to address some of the health inequalities that have been identified within the profiles. The idea is to promote and use these for local authority use, for wider system use, and for community and service development. Really trying to push towards a case of using an evidence base as much as possible within the work that we do. And these profiles are really a great step towards achieving that. Next slide, please. The limitations of the community health profiles, they will naturally have limitations. The main one is that at the moment, the profiles that have been produced do contain census data from 2011. We are aiming to produce update summary pages for the 2021 census data once all of that is released, which will be in the upcoming months. So the profiles that have been published will have that updated census data on it. We must therefore take conclusions on populations with caution, particularly some populations that might have changed significantly in the last 10 years. In terms of the profiles that are going to be published, the next batch of profiles, they will contain the 2021 census data. So it's just the ones that have been published so far. That's just a limitation with them at this stage. There are also sometimes some limitations in data collections. Some populations, for example, may be grouped together. A really good example of that is the deaf and hearing loss profile. People who are born deaf or born with hearing loss are going to be very different to people who had normal hearing and experienced deaf or became deaf or experienced hearing loss later on in their life. Sometimes studies just group everyone together, and sometimes that can be difficult to get accurate summaries because those people might have different life experiences. There also may be sometimes missing data sets for communities. We can only work with the data that is published and is provided. What these profiles can also do is to help to put pressure on organisations to collect better data, so that we understand our diverse communities even more. And we are only informed by what the data tells us. Sometimes the evidence might not paint the full picture, and that's where the engagement partners come in, and they can help to put the evidence into action. They can also help us to see if there's any missing gaps or missing health inequalities that they think that should be explored. So they're all community engagement partners. And yeah, it's really important to bring them in and to make sure that they're included within the conversation. Next slide, please. So the first Menti of today, it's just a really good opportunity for us to find out how much the community health profiles are being used. Hopefully, given that we've got quite a lot of people that aren't usually attending our webinars, there may be quite a few people who are unaware of the profiles at this stage, and that's not a problem at all. The idea of these webinars is to help to talk about a health related topic, but also help to push these profiles and make as many people aware of these profiles as possible. So I'm just going to give it a few minutes to see the answers come through. And if anyone has any issues accessing Menti, then please just mention it on the chat. Thank you. 14, can definitely push that up. I can see the little man in the bottom right corner, so I'll be watching that to make sure that we've got a few answers coming through. So if people can put those through, not going to be shortchanged by it. Thank you, Hannah. That's really helpful. Hit a quieter period. Brilliant. Next slide, please. I think you will still be able to answer them afterwards as well. We also would really like to collect demographic data. We really want to make sure that we're talking and engaging with our diverse communities as much as possible. We want to see if there is any gap in terms of people that we're not engaging with and people that aren't attending these webinars. If you really don't want to answer, or if you feel like it's not appropriate to answer, there is a prefer not to say option as well. And by answering the question, you're giving us consent to use this data for our own data analysis. Your data will remain confidential, so we won't be sharing any identifiable characteristics from this. Next slide, please. Brilliant. What is your age as the first one? Great, can see them flooding in now. 21. Okay, that's great. That's around about the same as we had for the question one. Next slide, please. How would you define your ethnicity? And that doesn't necessarily have to be in something that has been categorized for years. If people can just put how they define themselves, that would be great. Great, good to see some variety in terms of the ethnicity of the audience, which is great. Next slide, please. And what is your religion? Hopefully we see a few different religions and faiths coming in here. Really important in the context of cervical cancer that we're understanding the different needs and cares that fall into different ethnic groups, different cultures, and different religions. So really want to make sure that that the audience is diverse, so that they're helping to find out some of the information and find out some of the resources that we'll share as well. Next slide, please. Brilliant. Do you consider yourself to have a disability? Again, same applies. We really want to make sure that cervical cancer screening and care is accessible for everyone. That includes understanding different cultural competencies, but also understanding people who are living with a disability as well. And you'll see within the profiles, when I talk about some of the health inequalities that the profiles have found, things like ethnicity, disability, LGBT plus circumstances will be brought up. And we can see some of the challenges that people have in accessing cervical cancer screening. Next slide, please. And the final one, what is the first part of your postcode? If you're not from Birmingham, that's not a problem at all. We want to capture to find out if we're missing any areas of Birmingham in terms of people, in terms of areas that people live. The results are hidden for this one, and it is just the first part of your postcode, so it's not identifiable, but it's just allowing us to put the have an idea of where the general region is in terms of the postcode. Stella. Stella, if Stella hasn't been able to access Menti, then if I can ask somebody in the team to capture that and include it just when we're looking at the data. Brilliant. Next slide, please. Cool. And so the next section talks about the community health profile. So I've pulled some health inequalities that are specific and relevant to each profile. I've pulled some of the key information from those in the next slide. So if you could start with the next one, please, Jordan. So the trans community is one that faces lower rates of cervical cancer screening. You'll see that some of the barriers of cervical cancer screening include GPs' lack of understanding of trans health, discrimination from healthcare professionals, and increased gender dysphoria from the screening process. I think it's really important to make sure that we're using trans inclusive language and making sure that the language that we use when we're talking about cancer screening or cervical cancer screening is really relevant to each community. For example, in this case, with the trans community saying women and other people with a cervix, that allows it to encompass people from the trans community. You'll see that 58% of eligible trans people have undergone cervical cancer screening, which is significantly lower than the overall cervical cancer screening rates. In the trans actual survey, over a quarter said that they always or often avoided their GP for cervical cancer screening checks, which is a very high percentage. And it is also recommended, that trans and non-binary people consider having cervical cancer screening if they've not had a total hysterectomy and still have a cervix. Next slide, please. So this slide contains some useful resources. So if somebody can put in the reducing cervical cancer screening inequalities for trans people, we will share this with the webinar as well. There's some cervical screening for transgender men, an NHS video that can be found on YouTube. And what this is really doing, the link, from PHE screening is really helping to provide case studies and stories of trans males who might have undertaken cervical cancer screening. I think the case studies can be really important for demonstrating how their experience was, and hopefully it can be motivating to people from the trans community to read about people's stories and to find out that their experience was great and that they were able to correctly be screened for cervical cancer. So I really encourage everyone to read this, but definitely people who work regularly with the trans community. Next slide, please. Brilliant. The lesbian community, again, significantly lower rates of cervical cancer screening. So average in the West Midlands between 48 to 55%. And this is actually lower than the average rates of screening in the general population, which is 81% of women aged 25 to 64. So really significantly lower. Although the rates are low in terms of attendance, actually 91% of lesbian women know that cervical cancer screening is necessary. And that really goes to show that there's some barriers in terms of them accessing the care. They know that the care is important, but for whatever reason, and some of the barriers can be explored further, they are not attending as much as they know that they should be attending. And another study in 2008, 1 in 50 lesbian women were refused a smear test, even though they requested one. I can just see in terms of why that is, I think we'd have to go into the study to find that more. I would hope that by 2008, some of that has changed and some of the landscape has changed on that, with it being 15 years ago. I'm not sure off the top of my head why that is, but hopefully the study could tell us further. But it will most likely be due to some of the barriers within care of how lesbian women are treated. Next slide, please. And yes, Sue, the presentation, which will be shared with all attendees, has the references at the end. So you can see the numbers in brackets. That number 3 is embedded throughout the presentation and will be included at the end. In terms of South Asian communities, again, rates are lower. 61% of Pakistani participants were non-attenders at cervical cancer screening, 66% when we're looking at Indian participants. The Bangladeshi community health profile has discussed some of the barriers to cervical cancer screening. There being a barrier with a male doctor or nurse being present can be something that stops Bangladeshi women from wanting to attend cervical cancer screening. There also is the belief that symptoms must be present to be screened, fitting around family time and feelings of embarrassment, shyness, and shame. Next slide, please. In terms of the Somali community, again, some more barriers to screening, hesitancy to use a male practitioner again, embarrassment of FGM, so female genital mutilation, perceived low susceptibility to HPV and cancer, and distrust of the healthcare system. In terms of cancer screening, the limited data and information on the take-up of breast and cervical cancer screening by Somali women shows that screening is infrequent for both types of cancers. So this doesn't appear to just be a cervical cancer screening issue, but a breast cancer screening issue as well. That just really highlights and demonstrates how much the barriers are really impacting Somali women and other people with a cervix from accessing healthcare. Next slide, please. The Sikh and Muslim community health profiles, we don't actually have data published for them, but what we have done, and sorry, that's because cervical cancer screening by religious background is not actually available and is not published. However, if we're thinking about Pakistani, Indian, Bangladeshi and Somali community health profiles, we can assume that rates of cervical cancer screening are lower in Muslim and Sikh women and other people with a cervix compared to the general population. Next slide, please. And I will now pass on to Donna, who's going to speak a little bit more about some of the barriers to cervical cancer screening and also ways that we can overcome that as well.
Thanks, Joe. Hi, everybody. Thanks for having me today. So as Joe's already said, my name's Donna Brookes and I'm a general practitioner specialist champion in public health. And I'm also Deputy Course Lead on the Fundamentals of Practice Nurse course at Birmingham City University. And I work clinically too. I'm a practice nurse at Jiggins Lane Medical Practice in Birmingham. So I do a little bit of everything, and I'm hoping to bring a kind of practical view from a healthcare professional point of view to my part today. Could I have the next slide, please? So first of all, I wanted to show you a video from the Joe's Trust website that's aimed at patients as a guide to cervical screening.
your guide to cervical screening, the smear test.
My cultural views are very westernized, but I'm constantly finding that when I meet people within my community, their traditional values or their certain viewpoints prevent women from seeking help.
Educating, getting people more aware of what they're going to do. I think more time should be spent. It's not a procedure that should be rushed over.
Because I can speak English, that's okay. But a lot of the Chinese people that I work with, if they don't speak the language, if they receive the letter, they don't know what to do with it.
Specifically in the ethnic community, in the diverse cosmopolitan community, there is absolutely no awareness at all, and some people actually ignore the letters they get from the doctors to go for a smear test. I think a lot of women don't know what a cervical smear does.
All women are born with a cervix. A smear test checks the health of the cells on the cervix. Changes to the cells, also called abnormal cells, can sometimes lead to problems like cervical cancer. Being screened regularly means that any changes can be spotted and treated early to prevent cervical cancer. So a smear test is a very important test. You are invited for a smear test from age 25 to 64. How often you are invited depends on your result and where you live. It may be every year, every 3 years, or every 5 years.
It's a free service to all women, so go and do it.
My experience is it's always been a female nurse that has done my smear test. However, if you have a concern that it may not be, you're free to ask.
The nurse has been trained and has lots of experience doing smear tests. Anything discussed in the room will be kept private and confidential, and the door will be locked throughout the test.
I was sat down, I was asked about the last time I'd had a smear test. They just confirmed my address details. The nurse then explained what the procedure was and what would happen. She told me that she'd require me to take my underwear off. So she walked away, she drew the curtain. The nurse should give you privacy, and there should be some paper left on the side to allow you to cover yourself once you've removed your underwear. She told me how she required me to lie down comfortably. As she was following through with the process, she was telling me what she was going to do as she was doing it.
It's not painful, it's uncomfortable, but it was fine, mostly because my nurse made me very relaxed by talking to me and just making me feel comfortable and at ease with the whole thing.
So deep breathing exercise and think of nice things. Yeah, just try to relax the mind and the body itself as well.
It's uncomfortable, but as I said, it's very quick. And after that, you all forget about it. The minute you come out of there, it's fine. It's something you can live with it.
The cells are sent to the lab to be tested. The specialists in the lab are looking for a common virus called human papilloma virus. If they find HPV, they will look for any changes to the cells. There are hundreds of different types of HPV, and only a few are serious. These serious types may cause changes to the cells of the cervix, and over time, this can lead to cervical cancer. Anyone who has ever had sex or skin-to-skin contact of the genital area, even if it is just with one partner, will probably get HPV at some point in their life. There are no symptoms, and it usually goes away on its own. A few weeks after your test, you will receive a letter in the post. This will tell you the results to your test and what to do next, if anything. Most test results are clear, which means there is nothing wrong at all. If the test results are positive, you will be asked to go for further tests. Most of the time, changes to cervical cells will not lead to cervical cancer. Sometimes the cells will go back to normal on their own, and sometimes changed cells will have to be removed for everything to go back to normal. If abnormal cells are not spotted and treated, there is a chance they may develop into cervical cancer.
Would I ask my friends to go? Yes, I would. I think, we as women, we need to empower ourselves.
It's not worth worrying about it and putting the test off for several months because the test is over in 3 minutes. So just go and take it.
Because it's important, it needs to be done.
It could save your life, so do go for it. Yeah. Okay. Yeah.
And remember, smear tests save lives.
Thank you. I just wanted to share that video. It's one of many that's available on the Joe's Trust website. And I think what I like about the video is it gives a perspective from a patient point of view to make it more relatable, because if we think about how patients receive information and how they receive an invite to cervical screening, it's often a letter or a text message, and it's not very personal. So it raises a few issues in this video, that time needs to be spent, and that it's not just a quick invite or a quick appointment. We need to be offering reassurance to patients, and we need to reassure them that their information is kept private and confidential. And as it was mentioned in the video, that the nurse, if they want it to be, most of the time it's female, but if they're unsure about that, then we need to be reassuring them, especially if that might be a reason that they're not attending. So all these videos gives patient information of what to expect, and it also makes sure that we're not assuming that patients know what to expect during that appointment, because sometimes they don't know what's coming. So like I said, the Joe's Trust website has lots of information and videos available, and it's also got information available in different languages as well. So it's a really good resource for both patients and healthcare professionals. So it's worth us maybe sending videos out to patients too. So a lot of patients receive text messages. We can also send these videos along with a text message to the patient. Could I have the next slide, please? So today's webinar has hopefully highlighted that there are a variety of reasons that our patients don't attend, and it's important that we don't make assumptions as to why. We need to look at increasing community education and engagement, and we can do this by working strategically with not only the GP practices, but also looking within our local organisations as well. This could be pharmacies, community centres, local clubs, support groups, mother and toddler groups, and also by contacting local community champions for support. So I wanted to kind of raise that it's not always the GP practice that patients will want to come. It might be that we have to go to them in some of these environments to find out why they're not attending. Community engagement, including face-to-face discussions, is critical in the success of raising awareness. As clinicians, we need to determine how our target population want to be communicated with. For example, this may be phone or letter, or it might be where they want to be communicated with, for example, at home, a community group, or only in a GP setting. So we need to think about, would patients be more open to the information that we give them if we went to a community group, for example, or to a local club, or if we went out to their home? Or would they better prefer to discuss this one-to-one in private in the GP surgery? It's important to just note that not all patients would prefer the same thing, so we need to be able to consider a variety of options available. So we also need to think about our target population, what they want or need to know. For example, we've discussed already in the webinar that there's a lot of myths around cervical screening. And are there any myths or concerns that we can address? If we have a better idea of what these misconceptions are, then we might be able to get these patients in for cervical screening. But first of all, we need to find out what their issues are. And like I've already said, we can't assume that we know the misconceptions. Once we know why our patients aren't coming, then we might be able to put together some more bespoke resources. So we might be able to put together a personalised text or a personalised communication event where we can speak to our population of patients. Can I have the next slide, please? So like we've already said, when we understand why patients don't attend, we can overcome this barrier. And sometimes it's that patients can't easily access cervical screening. So we need to consider offering cervical screening appointments at different times. So this could be weekday evenings or weekends, and this can sometimes avoid clashes with patients' work or childcare or other commitments that patients may have. And it's also important that we let patients know that we have availability of appointments at convenient times and give them the option of out-of-hour services as well. Or if we don't have these available already in the practice, that we try and make a plan, even if it's like a once a month evening clinic or a once a month to go into the community. We need to start thinking of other ways that we can access our patients. It could be that we consider hosting a drop-in clinic as an alternative to an appointment. So it's important that we reassure patients that they're in control and that they can come and have a chat with us without needing to have that test straight away, because that can sometimes be a barrier in itself, that patients think if they make that appointment, then they're going to have their smear on that same day, and that's not the case. So some patients may feel better coming in for an informal chat to discuss what the test involves and to talk to any concerns that they may have. It might be that we want to link up with the local learning disability nursing teams, sexual health providers and other experts so that we can jointly support patients with specific needs. And also check that your surgery has access to equipment for somebody with a physical disability, for example. To make sure that other members of the team are aware of patients who may need a different type of support to understand cervical screening. As Joe's already mentioned earlier, for people who are transgender or non-binary, inequalities can exist for these individuals because they do not know which screening programs they are eligible for, or they might not be invited to screening because of the gender they are registered with at their GP practice. So it's important to note that trans men and non-binary people assigned female at birth are registered with a GP as male. They'll not routinely be invited in for cervical screening, but they can request screening. So it's important that we consider this group of patients when we're looking at recalls that we can put together in practice. To make screening more inclusive, we should consider and understand that not everyone attending cervical screening will be a woman. And this should be communicated to reception staff as well, because sometimes it's them who are accessing patients first. They might be the first person to speak to a patient when they phone up to make that appointment. So it's really important that everybody's aware of this. We need to expect that trans and non-binary patients are going to access this service and treat them like any other patient and not as an unusual or unexpected patient. We need to look for ways that make patients feel comfortable and also give an opportunity for them to access the service in a different way if needed. Joe already mentioned earlier that it's really important to consider the language that we use and remember that language really does matter. It's important to use inclusive language, and as Joe said, Cancer Research UK and Joe's Trust have broadened their language already around screening to include women and anyone with the cervix. Next slide, please. So we need to think about offering interpreters, and this could be in person or over the phone, and also translated information. As mentioned, there's lots of different resources available on Joe's Trust. There's also lots of resources available on the government website in different languages as well. There's easy read versions of invitation letters on resources, and I have collated a useful resources poster which will be shared with you after this webinar today. I've put some information for trans patients, for patients that can't access, who might have a low literacy, patients who have learning disabilities. There's lots of useful resources on there which, if you're not already aware of these, it's really useful to have in your practice. We might need to consider as well offering extra time for patients for cervical screening appointments, so that we can answer questions and explain the test fully. And like I've already said, working with local learning disability nurses to see if there's any specific support that they can offer patients. And some patients with living with a learning disability, the invitation letter that gets sent to them might not be accessible, and that's difficult for them to then make an informed decision about screening. Some patients have low literacy. The UK literacy is generally low, and medical information can be difficult for many people. So we need to consider the information that's being sent out and see if we can put it in a more easier to understand way, and approach it not just as a simple letter that gets sent out, that we make it more personalised to our patients. Patients who don't have English as their first language, the invitation letter may not even get read. It might not be accessible for them at all. So it's something that we need to consider for our patients who don't talk English, that we have another way of communicating with them. And we need to consider that patients that have come to us from a different country, they might not have routine screening programmes. So the concept of cervical screening, it might be unfamiliar to them. And like it was mentioned earlier, there's often misconceptions that you need symptoms to have screening, or that you need to have had sex to have screening. There's lots of things that we need to consider, and we need to find out what these misconceptions are so that then we can overcome them. Can I have the next slide, please? So some points to consider when trying to understand our local patient demographic. So we need to look at what age ranges our patients are, and also what ethnicities are represented, because these will be different depending on which part of Birmingham we're in. We need to consider what languages are spoken, what cultures are represented, and if there's any other demographics that we need to be aware of. So we need to consider the patients that are attending cervical screening, but then we also need to consider the patients that aren't coming and the ones that are overdue their cervical screening. So it's really good practice to audit the patients that aren't presenting, and then determine how we can reach these patients. Consider asking patients who don't attend why they don't attend, and then we need to help them make an informed decision. So I think the main drive is to make every contact count and discuss the process of cervical screening, and to listen to patients' concern and try and build up a rapport with our patients so that we really get to know them. Think about posters in waiting rooms and information in toilets in the practice, sending out text messages that are personalised, asking patients to come in for an informal chat. Look at the local groups in your area to see if there's anywhere where you can hold an education session or a cup of tea and a chat about cervical screening session. And I think the most important learning point for me is that as a community, we don't ignore this issue, and we look at new ways of getting patients to come in and to improve the uptake of cervical screening. It's really important that we get to know our communities and the people that live in our communities. And I understand fully the pressures that we're under in healthcare as professionals, but we need to work together and think of new ways of getting patients in, and not just accepting when patients don't attend, and ensure that patients that are refusing cervical screening are making an informed decision. I also wanted to add that it's important to share successes as well. So if anyone has any ideas that they've used to get patients to come in, or if they've held any education events, it'd be really good to share that practice and share it with others. Thank you for listening, and I'm happy to be contacted by email to help support you with improving the uptake of cervical screening. And as I've already said, I'm happy for the resources poster that I've made to be shared. And if you do come across any resources that I haven't included, then I'd really love to hear about them so we can all share best practice and information.
Thank you so much, Donna. That was really helpful and really important to learn how it works in a practical context. We had all the stats and figures from earlier that showed where the rates of screening are low, but it's really important to make sure that we're sharing resources and best practice, as you've said. I did see someone have a hand up. Has anybody got a question? No, maybe it was meant to be a clap. Sarah? Sarah?
Yeah, I was just thinking about how to attract people into the practice who don't necessarily come in, and I know from my previous practice we had a dedicated person that actually rang people personally for them to come in, but also that dedicated person then also could cross-check whether they're on any other register, for example, learning disability, and then I suppose would be able, if we had the resources, would be able to then send out a bespoke picture letter, for example, you know, something that, as you say, was more accessible. The practice did that out of their own money, and they couldn't sustain it really. I think it sort of needs to go to the authority that certain practices, like inner city practices, where you've got a lot more of an ethnically diverse, you know, if it's weighted according to how many, you know, people are on your learning disability register, all the other groups, that the actual authority, the screening group, they should actually pay them a specific amount of money that's ring-fenced for these extra resources, in order that you can have the time and space in practice to actually do this, to be more, you know, for example, somebody that's if you've got somebody on the LD register that perhaps needed more time, that person, that dedicated person, could then book a double appointment. Or, you know, if there's something in the notes that felt that they actually were very anxious, again, they could actually then make the appointment a lot longer, add in resources, get the right interpreter, all those sorts of things. But I do think that there should be some more funds ring fence for that, or extra incentive. Yeah, I think because they have to spend so much more time doing that compared to other areas where they don't have so much of a problem with attendance. Yeah.
Yeah, I completely agree with what you're saying. It's really difficult because, like you said, it's a time issue. But you know, it's important that we try and overcome this by speaking to the practice managers, by speaking to the partners, speaking to the local training hubs to see if there's any funding available. Speaking to the learning disability nurses to see if they can help us, because we can't do it alone. And I think that's what we're trying to kind of talk about, really, is that we're aware that patients aren't coming in, but we need to help them access the services and make reasonable adjustments, like you were saying about patients with learning disabilities. If they need a double appointment, then that needs to be made available to them.
Yeah. Unfortunately, I think that the practices need business incentives to do it, unfortunately. Yeah. So I think it needs to come from the top down in a way. You need to sell it to practice managers and somebody on the CCG to be able to
Yeah.
wait to
I think you know, in like making change in practice, however small a change is that you manage to make. So if it's that if a patient doesn't attend for their appointment, you can then phone that patient and speak to them during that appointment time. You could maybe create a poster for your local group, wherever, you know, there are little changes that we can make that will have a positive impact. I understand we can't change it all. I know, you know, we need funding, but at the same time, we can't just do nothing. I think we need to try and be proactive and working together with local practices as well, to try and drive some change forward. But I do completely agree with you about funding.
Well,
Yeah,
it's
thank you, Donna.
very, yeah, sorry.
I'm really sorry, Sarah. I'm just
Okay.
in the interest of time. We'll definitely include that. And Donna, thank you. And I completely agree as well. If in the communities team we can collect that as feedback from the audience, and we will be escalating or talking about what we can do in public health to make sure that those conversations are being had as well. And I'm sorry for cutting you off, but just in the interest of time, because I know there's a couple more things that we've got to do in this presentation. There was a hand up, I think, from Kafila. Has that hand now come down?
Yeah, no, just really quickly wanting to add, I think really hearing, sorry, I didn't catch the whole thing, but I think there's definitely some joined up thinking to do around this. So just to say, I work for Macmillan, you know me, Joe. So I mean, the conversations that are coming through around health promotions, more sort of joined up working. So we know the breast cancer team are doing various initiatives to go out to community locations, to try and engage with those communities. I think it sounds like it's overlapping, and it feels fantastic at the same time, because wonderful to hear that, you know, all those things that you've said, they're absolutely, you know, vital right now, going out to communities, listening actively, having those conversations, destigmatizing. I think that we probably need to do some joined up thinking, especially around the whole screening initiative, because the problem is that we're fatiguing the community. People are going in, it's getting overwhelming. I've connected a few individuals myself, and I think that it would be really wonderful if we could, if Joe, if you're happy to do this, could we coordinate something where we could all come together, people that are working on screenings, we could maybe target larger sort of organizations, community groups, to help us to trickle that information down, and us to have more joined up thinking. So breast aren't going in at a separate time. If we all do sort of a health promotions agenda, it will be a bit easier for the community to manage the request coming in.
Yeah, I think that's fine. We can build that up together, and we have a few things in public health. So we have our Bolder Healthier champions who can work as community advocates for helping to share the information, and as well within the communities team, some of the communities that we work with, they should be helpful for getting that information across. So yeah, that's absolutely fine. If we can just go on to the Menti, because I know we've got a few questions. What we don't want to do is just have a presentation where we talk at you and discuss all the issues without everyone else having the opportunity to input anything. So if we can just go on to the first question, and just to remind the code 45195803. We've talked a lot already about barriers that people face. We want to give people the opportunity within this webinar to talk about the barriers that they face. If that's any new barriers that we haven't talked about so far, then that would be brilliant to input that. Equally, if you're reinforcing some of the barriers that we've already talked about, then that would be great. A few people who don't face any barriers. Work getting in the way, time commitments. I think it's important to highlight that the cervical screening process is great, and some people saying that they don't have any barriers is brilliant. Not everyone will face barriers within cervical cancer screening, so it's good to see that some people within this are talking about not having barriers, which is good. Yeah, getting through an appointment and getting through to the GP. I think an issue that's not specific at the moment, just to cervical cancer screening. receptionist understanding, so maybe some work that could be done with the GP practice and the receptionist's work and time, laziness. Brilliant. If we could move on to the next slide, please. So the next one, how can we support the community with cervical cancer screening? Again, anything that we've talked about so far that is reinforced would be great. Anything new that that we haven't discussed within the webinar would be great as well. Particularly any resources or any links that people have, as Donna has already mentioned, sharing best practice where possible. More sessions in the community of interpreters. That's good. TikTok videos. Definitely would engage with a different audience. I think if you think about different social media videos and different ways, particularly as well if some of those were taken through to social media apps that might be used by different communities, or even through radio or TV channels that are used by different communities as well. Cervical cancer screening link up, videos in different languages, raising the awareness and explaining importance, joining up with charity organisations, and a Kafila from Macmillan. We've already partnered with her, so hopefully we've started to do that a lot more, and we can keep going with that. Posters in certain places, such as community centre and places of worship, I think is a really good point, making sure that we're providing information in areas that people frequent, and events within the community. Brilliant. Some really good feedback there. Thank you. Next slide, I think, is the last question. So what other methods could we use to spread awareness within communities that we do not engage with as frequently, or people who don't access the services as frequently? Are we thinking too much within one particular engagement method, or focusing too much in one area? Are there other ways that we can get this communication out and the importance of cervical cancer screening and prevention? Is there other routes that we can explore to make sure that the communities that we're not engaging with are being heard? University students. It's good. Going to give it another minute or so. I know that we're just at 11 o'clock, so if people do have meetings at 11, then that's absolutely fine leaving. Relaxed environment, asking them, co-producing. I think the relaxed environment's a really important one. I think a big barrier that people face is fear around the screening process. So providing a safe and relaxing environment to people can be really helpful to make sure that they're heard and listened to as well in that. Awareness days in mosques, quite a lot of talk about faith, so one for our team to catch, and community champions, something which I've highlighted already, which is good. Brilliant. Talking to mosques imams, out of office time clinic. I know Donna touched on like a drop-in clinic, which would be good if we could offer that too. Podcast, again, that social media angle. And next slide, please, Jordan. Is trans screening data local or national? I believe that the study is national. Yeah, and I'll check that on the presentation if I'm wrong and notify people that it's local, but I believe it's national. It's in the reference list at the end, which we will share with all participants too. Brilliant. And next slide, please, Jordan. Yeah, there you go. Transactual, trans-live survey enduring the UK's hostile environment. So that is national data. Brilliant. Thank you, everyone, for attending this webinar. I really hope that you all found it useful and informative. We've got a few links and resources and poster and leaflet to share, which we will share with everyone. Really actively encourage people to share that with all colleagues and connections that they have, particularly groups, as I've identified already, that are hard to engage with, or people that don't attend cervical cancer screening as much as the general population. Those general population numbers can still be improved and increased as well. So important to make sure that we're hitting all of that demographic and making sure that everyone is aware of the importance of screening. If you've got any questions, communitiesteam@birmingham.gov.uk. I know Donna's popped her email in the chat as well, so thanks, Donna, for that. And I know you've offered people to reach out as well. But yeah, thank you very much for everyone attending.